A very warm welcome to Glasgow City Innovation District's Made in Glasgow webinar. As part of the University of Strathclyde's Engage events, we are delighted to welcome health technology experts as they discuss how the global pandemic has ignited a revolution in the health technology sector to help improve and transform health and social care. It is fantastic that many of you have signed up today. I appreciate you have access to many webinars now, and with many people suffering from Zoom fatigue, but I do hope you will find today's session interesting and of value both to you and to your business. Before I start formally introducing everyone, I thought we'd better get some housekeeping out of the way. If you have any questions, can you use the Q&A function, which is available at the bottom of the Zoom screen. The chat function is disabled on this webinar, but the team are here to help, and we will have time at the end of the webinar to ask questions. Today's webinar is being recorded, and we will share this with you at the end of the session. Today's session is brought to you courtesy of the Digital Health and Care Institute, and I'm particularly delighted to welcome not one, but three highly qualified speakers. Professor George Crooks, OBE, Chief Executive Officer, who is going to provide us with an insight into who DHI are, what they do, and the potential opportunities for digital technology companies within Glasgow City Innovation District. Michelle Brogan is the Service Development Manager, who is going to talk about ScotCap, an exemplar project, and how it was brought together with the best of commercial industry, academia, and public sector to develop a real solution that can be adopted and scaled across Scotland and beyond. And our third speaker is Shalnar Chute, Chief Technology Officer, who will showcase the DHI exchange and how businesses can work with DHI systems going forward. As for me, I'm Anne-Marie Campbell. I'm Head of Property and Planning in Glasgow City Innovation District, which is a partnership between Glasgow City Council, Scottish Enterprise, Glasgow Chamber of Commerce, Entrepreneurial Scotland, and the University of Strathclyde. For those of you who don't know an awful lot about the Innovation District, it is a 6x6 city centre block covering somewhere in the region of 170 hectares. And just to give you a little bit of perspective, that's the equivalent of 420 football fields. It goes from the Royal Infirmary across Queen Street and down over the river to Glasgow College Riverside campus. The district is a hub for entrepreneurship, innovation and collaboration. It builds on Scotland's rich tradition of scientific excellence and industrial collaboration, and it's a place to eat, work, live, play and innovate. Digital Health and Care Institute is an organisation tasked with delivering innovation in digital health and care that will not only help Scotland's people to live longer, healthier lives, but it is also creating new jobs for the economy. And this afternoon, we are going to hear about scientific excellence, innovation, and collaboration. I think you will all agree we are about to begin an incredibly interesting and informative session. I'm particularly delighted to welcome Professor George Crooks this afternoon. As mentioned earlier, George is the Chief Exec of Digital Health and Care Innovation Centre, Scotland's National Innovation Centre for Digital Health and Care. George was previously the Medical Director for NHS24 and the Director of the Scottish Centre for Telehealth and Telecare. He was also a General Medical Practitioner for 23 years in Aberdeen, latterly combining that role with that of Director of Primary Care for Grampian. George is on the board of the European Connected Health Alliance and is currently a board member and past president of the European Health Telematics Association, and is also an adjunct professor of telehealth at the University of Southern Denmark. George was awarded an OBE in the Queen's Honour List for services to healthcare. So without any further ado, I am delighted to hand over to George.
Great, Anne-Marie, thank you. Thank you very much indeed. I'm aware that Michelle, Chal and I are the only thing standing probably between you and your lunch. So I hope that the next hour will pass by very quickly, not from a time point of view, but because we're going to share some interesting things with you. So without more ado, can I have my next slide, Michelle? And I'll set the scene, if that's okay. All right. Okay, no surprises for guessing where that is. This is the TIC building at the University of Strathclyde, and the smaller building next to it is the Inova building, and that is where DHI is based. We are on the first floor of the Inova building, not actually looking onto the main street, but onto the piece of grass at the back. So when we used to be in the office and when we did have a summer, there were some pretty interesting things happening on the grass out the back of our building. The reason I always start my presentations today with this slide is that it's been over a year now since we were last in the Inova building, and I'm going to reflect why that has been and what the opportunities that is going to create for us all as we move ahead to the future. Next slide, Jeanette. Next. So what about DHI? Michelle will click on and...
Sorry, I'm having some problems, George.
It's all right. It's the wonders of modern technology. Never work with technology, animals or children, they say. So we are Scotland's National Innovation Centre for Digital Health and Care. We're funded by Scottish Government and by the Scottish Funding Council, and we're one of 7 innovation centres. The key issue that I want you to take out of this slide is that we are here to address the societal challenges being experienced by citizens across the whole of Scotland, and use digital tools and services to help address those issues, while at the same time creating economic advantage. By economic advantage, that is supporting Scottish businesses to develop digital tools and services to address these big health and care issues that can actually not only help Scotland, but can then be sold across the rest of the UK and internationally. And likewise, stimulate inward investment into Scotland to bring global tech companies to our shores to collaborate with Scottish businesses to develop next generation services. Next slide, please, Michelle. So for us, it is all about collaboration. But before you can collaborate, you need to understand the environment within which we're working. Next slide, Michelle. Since Christmas 2019, our world has been turned on its head. Who would have thought in the run up to Christmas, when you were worrying mostly about what colour of wrapping you were going to put your mother's present in, did you think that an episode of respiratory disease in the Wuhan province of China was going to impact on the daily lives of us here in Glasgow? But the reality is it has turned our world on its head. Next slide, please, Michelle. But from a health and care point of view, it's created significant challenges. It has generated significant increased investment in the delivery of health and care services. But what I want to reflect on is that the NHS in Scotland, as well as the healthcare systems around the world, were wrestling with a number of challenges before coronavirus reared its head. First of all, we'd recognised that the way we were delivering health and care services were not sustainable into the medium and long term because of the inexorable rise in the cost of healthcare to governments. As a percentage of GDP, healthcare was increasing almost exponentially. Next slide. What that also sat alongside was the fact that we were all wrestling with a society that was getting older, requiring additional health and particularly care inputs. How were we going to manage with that? Next slide, Michelle. And in Scotland, as well as the rest of the world, there was a significant increase in long-term conditions. This is a piece of work that I commissioned as head of the Scottish Centre for Telehealth that showed the projected increase in patients with hypertension, diabetes, cardiac failure, and COPD in Scotland. And you can see that by 2025, we were going to reach a level where, in fact, our conventional services across Scotland couldn't actually see the number of patients presenting with those conditions. So things were going to have to change. Next slide, please. And along with this was the rising challenge of climate change. Now, climate change is interesting in that it is going to, if we do not tackle it, cause a greater degree of harm to the health and well-being of citizens of this planet than coronavirus ever can or will do. Healthcare is responsible in Scotland for about 6% of carbon dioxide emissions. In the US, it's about 12%, and in Africa, it's between 4 to 5%. Most is due to travel. Secondly, it's due to our procurement choices. So we do have to play our part, along with you and others, in achieving government's net zero carbon goals. Next slide, please. So that was what was happening pre-coronavirus. Where we are now is even more challenging. In 2020, there were 600,000 less referrals to hospital outpatient clinics in Scotland than in 2019, 155,000 less hospital admissions for conditions other than coronavirus than in 2019. And what that means is that there are a large number of people, and you or your family may be making up some of those numbers, who are sitting at home with underlying medical disease and have chosen, because of everything that's going on, not to access healthcare. And we know at some point these people are going to come forward and knock on the door of the NHS in Scotland, and they'll be presenting further down the life course of their health condition than they previously did. And that is at a time where waiting lists in Scotland have never been higher, and times for treatment have also never been higher. It is almost a perfect storm. So what are we going to do about it? Next slide, please. Well, what everybody talks about is we're going to invest more in buildings. We're going to build more hospitals. We're going to open more hospital beds. And what you will recognize is that during the early days of the coronavirus, and even up to quite recently, all the focus was on hospitals, intensive care beds, how many people were in hospital. That's what we normally talk about when we talk about healthcare. Next slide, Michelle. But the reality is that you and I live in communities. 95% of health and care in Scotland is delivered in community settings. So as we look to transform services, as we look to build new digital tools, services, and products to support your needs and my needs, these need to be focused not on hospitals primarily, but on communities. Next slide, please. That's our reality. We need to stop people being sent to hospital to sit in crowded waiting rooms waiting for treatment. We need to turn things on its head. Next slide, please. And the NHS in Scotland has recognised that. And so the focus over the next 18 months to 2 years as we recover is to move from investing more time and effort on treatment and post-event care and moving to prevention, detection, anticipation, and also on independent living. And in DHI, that's where we are focusing our time, and that's where we're trying to encourage digital and technology companies to begin to do more planning about how we can address these opportunities. Next slide, Michelle. So in coronavirus, we're getting ahead of the game by doing vaccination. Next slide, please. But in other areas of healthcare, we need to look at different things. So what are the opportunities? Well, the global pandemic has meant that we are engaging with technology in a way that we've never done before. Who would have thought we would have been celebrating birthdays, Christmases, using this type of technology? More shopping has been done online. We are actually having Michelin-starred food delivered to our homes. Who would have thought we'd be going down those routes? Citizens have changed their expectations about technology. The way they're using in their day-to-day lives has changed. Healthcare needs to grasp that opportunity. And that is what we are doing in DHI. Next slide, please, Michelle. So the future is all about thinking digital, but what do we mean by that? Next slide, Michelle. The future is really what we make it. So we need to plan for it and not let it just happen to us. Next slide, please. And in Glasgow, we've got a great opportunity to work together to do that. Let's not look to the past and try to undo the things that have already happened to us. Let's collaborate and work together to build a positive future where we can maybe harness the technologies that you have that you're deploying in environments other than healthcare that could actually be fit for purpose to build part of the solutions we need. That needs us to think innovatively and to work collaboratively. Next slide, please, Michelle. We need to look at healthcare spend not as a cost, because if you think of it as a cost, you always want to cut it. We need to think of health spend as an investment and how we actually leverage new companies to come into the health and care ecosystem to work and innovate alongside us, to develop new services, to solve problems that have been existing for a long time, but are ripe for being addressed in different ways. Next slide, Michelle. So we are looking at next generation services. So what do we mean by that? Next slide, Michelle. We're really saying we need to stop focusing on products and need to think an awful lot more about services. Next slide. We need to put the citizen at the heart of all we do, and we're going to expose you a little bit later on when Michelle talks and then Chal follows on afterwards about how we put the citizen not just at the center of their own health and care, which is a logical place for them to be, but what if the citizen became the point of data integration? What if the citizen actually had full control over their own data? Not simply the rhetoric that you've heard politicians talk about, that the citizen should own their own data. That needs to be our reality for the future. Next slide, please. And that can unlock a great number of opportunities, and Cha will expose that to you. But from my perspective, what it allows us to do is to unlock the knowledge, experience, and expertise that each and every one of us has as a citizen, and allow us to use that to benefit our own health and well-being, but equally importantly, those of our friends, families, and neighbours within our own communities. Next slide, please. And that is from a personal health perspective, but also from a business perspective. Because what if we could blend citizen-generated data with formal health and care data to get a much greater understanding about the lived experience of each and every one of us as citizens, to inform better health and care planning, but equally life and death clinical decision-making. Next slide, please. So our world is about recognizing that the public service doesn't change first. From a technology point of view, as Chal will share with you, that governments and the NHS likes to keep all its resources behind high walls, where it can cut the fences, where it can tend the gravel paths and pretend everything is ordered and neat. But the reality that you and I and our businesses don't live in that type of environment. Next slide, please. As I said earlier, we live in our own communities, but what we need to do in the Glasgow Innovation District is use that to our advantage. We need to use that as the rich meadow where we can innovate and grow new tools and services free of constraint to actually support citizens to make better informed health and well-being choices, to allow them to manage their own conditions and take responsibility for what they are doing in a way that has not been the case in the past. Next slide, please, Michelle. So that's really what DHI is all about. It's about bringing together technical innovation with service innovation and also business innovation. What are the business models that allow us to adopt solutions and also to scale them? So you as a company, when you're thinking about things, don't simply build the technology and expect everybody to be grateful for it. Put as much time and effort into working out what the service model looks like, and also what the business model looks like to allow for adoption and scaling. And that's what we in DHI do. We work with businesses to support them across those three legs of the three-legged stool. Each are equally important. Next slide, please. So for me, the last thoughts I want to leave you with, yes, technology is very important, but it is certainly not the be all and end all, because at the end of the day, next slide, please, it's all about people. It's all about how we improve the quality of life of you, your parents, your children, and generations to come by appropriately using digital tools and services to support us all do the right thing. Next slide, please. And the only way we do that is through collaboration. So DHI is there to engage with any business within the Innovation District who are interested to play in the health and care field. And Michelle is going to expose you to one of our large projects to give you an idea of the types of things we do and how we do them. And Chal is going to share with you how we leverage today's technology to build the next generation of services. So enough from me. Next slide, Michelle. I will now hand over to Michelle, who will take you into the brave new world of ScotCap. Thanks very much for listening to me. Michelle.
Thank you so much, George, and thank you for the invitation to come along today. Really delighted to come along and share some of the really exciting work that DHI is involved with. As George mentioned, I'm going to share today with you a bit of an overview of what is considered an exemplary project here, which shows the very best, I think, of what we've been able to achieve around bringing commercial, industry, academia and public collaboration. And it's really centred around developing a real solution for a real NHS challenge. And it's been delivered across Scotland, designed and delivered now as a care and diagnostic approach across Scotland, and also now is in the process of being scaled up, and also has attracted wider interest across other parts of the Four Nations, which is absolutely delighted. So I'm going to tell you a little bit about our journey. I'm going to show you a little video so you can hear some of what our partners' experiences have been of this, and then I'll finish with some sort of key headlines in terms of the impact for business, which I hope several of you will be interested in. So ScotCap really stands for the Scottish Capsule Programme. So this was essentially around looking at a point of care diagnostic test that could be used to detect people who have early bowel cancer symptoms or symptoms of lower bowel disease. So it really looked around this technology called colon capsule endoscopy. And what our aim was really was to develop and evaluate an innovative service approach to delivering this diagnostic approach and its readiness for adoption across NHS Scotland. So the actual capsule technology itself, which is really interesting, has been around the NHS for a number of years, but not used routinely across Scotland or across the UK. And what we wanted to do was to look at the opportunities to accelerate the adoption and use of this. The impacts are significant. We know across Scotland that there are over 180,000 colonoscopy investigations every year. So we know with increasing demand on services, there's a real sort of demand capacity challenge. We wanted to create additional diagnostic capabilities really for our NHS partners to allow for more timely diagnosis of services and give much more of these services approaches to take this forward. And really for us, this was really about trying to minimise and improve the patient experience. So particularly across the northern parts of Scotland, patients can travel for some miles to really reach hospital to have a bowel investigation or a colonoscopy. And we really wanted to understand about how that could be delivered closer to home, or a model could be evolved that would deliver that. And of course, there was an element of being able to generate evidence in terms of taking this forward as a diagnostic approach. So we kicked this off in 2018. the actual formal programme, but with all of these things, the wider investigations and into identifying partners started much earlier than that. So just a little bit about what the actual technology was. So you'll see here, this is the video capsule camera. So it's really a size of a vitamin pill, and it's disposable. So what really happens, the patient will swallow the camera, the small pill cam, and as it moves through the body, there's a belt and a recorder attached, and it captures the images as it moves through the bowel. It takes in the region of 400,000 images, and this is then uploaded to the recorder. Now, once the patient is wearing and has swallowed the capsule, is wearing the belt, they can go about their normal business. They can be at home. They don't need to take any particular time off work or sit in a waiting room or in a hospital to do this. So then after the bowel moves through the body within about between 6 and 12 hours, and after which point the camera, images are then transported wirelessly so it can be analysed and reviewed. So alternatively is something known as a colonoscopy. So I'm not sure if anyone has ever experienced this, but it can be a fairly invasive procedure. It's hospital based. It's very much, can require sedation. It's a really sort of different experience. So you can really see we were trying to kind of look at improving capacity and also the patient experience. What was quite unique about this project was really the approach we took in terms of trying to move it forward. So this was around development of an innovation partnership approach. So we very carefully selected stakeholders which really shared our vision in terms of moving this forward in Scotland, and sort of like-minded people who were able to come and work with us. So we're really delighted we secured sort of commitment from industry. We had NHS partners, our government colleagues and sponsors were able to provide continued support for the project. We had academic expertise and some of our enterprise agencies, because there was an opportunity here for economic growth in Scotland. So it was really about how we could bring all these different parts together. We stepped through the whole programme, step by step. I'm using sort of the Discover, Design, Evaluation sort of framework, which worked really well. One of the things that we pioneered through the project, which may be of interest, was something called an innovation partnership procurement. So we understand we were definitely the first in healthcare in Scotland, if not in the UK, to take this forward. So there's a lot more information on the link here just about what innovation partnership procurement is. But essentially, it's when there's a commercial arrangement to take forward R&D and innovation, which is competitive at the start. There's a competitive opportunity, and it allows then for further exploration and development without then having to continue with procurement after the service has been evolved. So it's very distinct from what might be sort of pre-commercial procurement, which we're probably more typical of using. And it's certainly been a great example of kind of how that type of innovative approach to procurement has really helped us move this forward. So also within the partnership approach, we shared resources, we shared risk and understanding how all this would work. We shared knowledge and expertise. And above all, I think, we were aware this is still innovation, we were still learning. And so we really were prepared to fail fast, really, and change direction, think differently, think on our feet. And also with that, have a very sort of strong governance model that overtook us with that. So sort of some key sort of, I think, enablers there. This is just a summary of our journey. So as I mentioned before, the formal programme didn't kick off in 2018, but DHI were very much involved from the initial outset with ScotCap. We established a dialogue with some international partners. We started back in sort of 2016-17 with an early feasibility study of how this would work in Scotland, and how we developed the case for change. This then allowed us to be able to secure much more investment for a bigger programme, establish the innovation partnership, and really beginning to understand how we should design this programme to sort of meet, to meet the vision that we wanted to have. And the bulk of the work really around ScotCap programme took place between sort of 2019-20, and I was one of the key leads involved in overseeing a large-scale evaluation of the use of colon capsule endoscopy across the north of Scotland. So we worked with Highland, Grampian and the Western Isles Board with 9 test sites where we dispensed and used, the service for patients. Part of that involved co-designing and co-producing a service delivery model with patients and staff to ensure that the model fitted and worked well with practices, and also part of that was about understanding if this was to become a scalable service in Scotland, what would some of those requirements be. The key part of our work was we had academic evaluation aligned to this. So we were fortunate to work with University of Aberdeen, who completed a clinical effectiveness and efficacy study, and also our colleagues in the University of Strathclyde, who led a patient acceptability and experience evaluation. So overall, we evaluated the service for about 500 people and sort of used that as the basis for evaluation. So this was, once we had our interim results for ScotCap, we were able then to build a business case around the data. We were then able to bring together some of the health economics associated with what would be required to implement this wider in Scotland. And we also took the important step to begin to consider the implementation approach and how this would work. We know from our experience that so many products don't necessarily scale within Scotland or globally, really because there perhaps isn't enough attention made to sort of the readiness for implementation. And then we started a national conversation really about how this could be taken forward. So where are we now? So the final evaluation of ScotCap coincided with the remobilisation of NHS services. So the ScotCap model and the programme was sort of commended as kind of moving forward as something that could form part of that remobilisation plan. And it's now being rolled out across Scotland, as I mentioned earlier. So it's seen as really having a significant contribution to challenging some of the cancer waiting times in Scotland. And the real sort of bonus, I think, with this approach is that it's non-aerosol generating. So whilst a number of other diagnostic approaches were unable to happen because of COVID, this was one that was able to continue. And as I say, we're very much involved now in supporting the national rollout. So great story, lots of really great insights, but I think you're thinking, okay, so what was the impact for the business? So we were lucky enough, we worked with 2 SMEs and a such much more larger company, but I think overall, when we speak to them, they can clearly see there were significant benefits for them. So some of them are just highlighted here: business growth, new jobs, expansion. As I said, some of the work is being moved now to NHS England. They're interested in taking forward a similar model to Scotland, so that's opportunities there. We've created a new route to market to supply the NHS. And then some of the secondary gains, which may be of interest, is George mentioned earlier about business model development. So being able to recast that with a Scottish context and being able to think about what would fit with the clinical priorities within Scotland. For business, I think it's really, DHI really helped navigate that process through the NHS, building contacts, relationships, and really being able to sort of understand the whole kind of innovation landscape. And what's often, I think, a key part of this is because business was part of this larger collaboration, we were able to leverage, quite significant high quality academic evaluation for the product and for the service, which I think is really valuable in terms of further business case development. And of course, this work has led to attracted other investments. So particularly around the colon capsule, there's a lot of interest in terms of machine learning and AI activities around trying to sort of review the recordings and the reportings and using that much more to accelerate things. So with that in mind, I'll just share this short video.
All the way back in 2014, we started working here with the Scottish Government, with the NHS Highlands, to figure out how could you deliver capsule endoscopy, or how do you can you deliver GI diagnostics in a better way, and capsule endoscopy was the way forward.
The capsule itself is probably about the size of a large antibiotic, and the patient swallows that capsule down.
It takes up to 35 pictures per second.
Really what it does, it creates another option or a choice for patients rather than having to go down the traditional colonoscopy route.
Scotland does not have the capacity it needs to investigate all the people that need an investigation.
The waiting time to have normal diagnostics, endoscopy services, the waiting time is expanded because we haven't been able to staff endoscopy units. There are a number of people who are waiting for diagnostic services with symptoms, and in that group there will be patients with bowel cancer.
A number of things worked really well in the project. The main thing for me was we got the service design right. And that wasn't by accident. A huge amount of time and effort went into that, using professional design researchers, supporting the clinical teams in developing a service model.
And I think we're really learning a huge amount about how to implement the service, how to make it really beneficial for staff and patients, and really how we can deliver this on a much wider and more sustainable scale.
All of that is based on evaluation, making sure we're getting it right for the patients, taking feedback from the patients to understand if it works for them, and as we move forward, making sure we refine how we deliver services that suit the needs of patients.
The one major piece that we instigated quite early on in the project was an innovation partnership procurement process. This was the first of its kind in the UK.
And that brought together not just government, academia, the NHS boards delivering the service, or the clinicians, the managers, patient groups, but also industry colleagues sat round the table with a common sense of purpose.
There's a lot of projects in the future that will benefit from the learnings that we've had throughout this process.
Already we've taken forward pieces of work as a result of ScotCap in a way that we probably wouldn't have done previously.
What none of us anticipated was the emergence of the COVID-19 pandemic, which coincided with the end of the trial.
The pandemic's obviously has changed the direction of travel, or certainly seen us scale up much more quickly than we would have envisaged. We need to do that in a safe way to make sure that we get it right, and that the patients are having a positive experience as part of that, and that we continue to listen to feedback and refine it as we go.
If you can go to your local general practice, your local pharmacy, and be supervised having your colon capsule endoscopy, not having to take time off work or find childcare, and not having to drive into town and find a parking space in a busy hospital. If we can make it so accessible, I really believe that we can change the incidence of bowel cancer in Scotland.
So thank you very much. If there's any more information on ScotCap, please do contact me, but without further ado, I'll hand over to Chal.
Hi, sorry about that. Double muted. I'll apologise in advance. My one-year-old just started nursery, so I'm under the first of many colds over the next few months. So apologies if I seem a bit lackluster and low energy. So I'm going to talk a little bit about designing for digital at scale. I'm just going to build on some of the themes that Michelle and George have described. And just walk you through some practical examples of how we can do this in a person-centered way. Next slide, please. And one more click. So yeah, so we run a kind of model within DHI called the DHI Exchange. This is where we use a mixture of physical and virtual environments to help with service transformation and design activity. We kind of mix a design activity, which George and Michelle have already described, with what we term simulation, which is where we support the integration of systems. Allowing, as George described, patient-held data and wearables and devices and applications to connect with clinical systems. We use fake data or simulated data to show those systems integrations working, and help build confidence in the fact that we can do this as an ecosystem, and we can do it in a way that's joined up. And then we run sort of demonstrations, and we give lots of art of the possible demos to again help with the confidence building, and we use it as a kind of virtuous cycle using previous rounds of simulation and live deployment work to support future design activities and build confidence in that way. Next slide. So yeah, so we spent a good amount of time in DHI in the first 3 years of our existence, helping businesses develop product and trying to help get it into markets. Whilst that might work for other innovation centres and in other markets, in the health and care market, it never quite cuts it. There are too many systemic barriers as things are to allow that kind of product push model to work. So a few years ago, we kind of pivoted to more of a model where we actually dismantle some of those systemic barriers, and that's more of a pull model where we work very closely with health and care organizations, commissioners, procurement people, and others to help build the case, help build the evidence, and help people be more adventurous in their ask of digital. So we do that through a few different kind of ways of working. The first is, again, providing these safe places to play and allowing people to feel comfortable with new methods and to de-risk them. Secondly, to sort of support commissioning. So again, a lot of this is, you can have the best product in the world, but if no one's asking for it, then there is no route to market. So we've got to help people get to a place where they're asking for what digital is capable of. Transformation. So you can't just bolt a new product onto an old way of working and expect to see a kind of cost benefit. And generally speaking, if you can't demonstrate favorable cost benefit, then it's highly unlikely that health and care services will deploy any given technology. And then next one is integration. So as we said before, we don't want to create new silos. We don't want new products acting in isolation. Almost all of the co-design we've done over 7 years now with citizens and professionals tells us people want communication, coordination, and integration. They want systems to talk to each other. They want to tell their story once. And so a key part of the ask now is how can we integrate things from the outset and de-risk them before we go into a live setting. And then lastly, empowerment. So we use all of the above components to fundamentally empower senior decision makers in the health and care communities to make active decisions to push the big red button that says, yes, let's buy this, yes, let's deploy, yes, let's evaluate and scale. Next slide, please. Some funky things going on this slide. I don't know what that is. That's fine. Thank you. So, yeah, again, within that kind of systemic barrier kind of breaking model, we undertake two basic phases of work. One phase is the simulation I described previously. So again, working with these safe environments to show modern digital services and products integrating with existing systems, and using that to kind of de-risk and raise awareness of what can be achieved, and then use the outputs and demonstrate the outputs of that to stimulate commissioners to then get to a place where we can kind of ask for funding and make a case for investment in transformation activities. And we would typically run living lab kind of processes where we look at a reasonable deployment and evaluation, trying to generate the real world evidence for investment decisions. Next slide.
Sorry, Chal.
That's all right.
Here we go.
So yeah, so lessons learned so far. So as I described earlier, we have been at this a little while. I've personally been here with DHI for all 7 years, and I've got plenty of scars on my back. And so we're here to help you not make the same mistakes that we and others have made in the past. So we have a kind of learning system that makes sure we bring forward that learning from one project to the next. Chief piece that you'll hear me always talking about is not focusing on products. And George already described it. We need to focus on services, but but at a technical level, we're more interested in reusable horizontal platform capabilities than we are with the individual applications, devices, and other products that might leverage those platforms. And I don't mean that to downplay the importance of a good product, but if the product can't connect, if it can't get access to the data it needs, if it can't act cooperatively as part of an infrastructure, then it, generally speaking, will not provide a cost beneficial outcome. And so we spend a lot of time focusing on those general platform capabilities that help others. Next slide, please. The other thing to consider when we're working through that kind of platform thought process is that co-design from end users, as we described before, is chiefly concerned, that people are chiefly concerned with how things connect, how they communicate, how they coordinate care, how they can activate services, how they can share their data, how they can avoid retelling their story over and over again. I don't want to fill in endless forms. I don't want to have to repeat myself to a variety of different clinicians and practitioners and apps and devices and online forms. Could I not just curate my story once and share it again and again? A diagram on the right was just kind of reflecting on the types of data. This is not just about clinical care and clinical data. There's a whole of life data set that if you're trying to personalize and predict, and if you're trying to get into some of the fancier kind of machine learning based preventative and personalized care models, then we are interested in physical and environmental, social, economic, and individual behavioral data as much as we are the kind of core clinical data. Next slide, please. So to that end, we've focused on translating those requirements over many different projects into common menus of enabling infrastructure that deal with data exchange, structured data sharing, consenting, digital identity, notifications, messaging, etc. Different ways and different places to store the data, different ways of interacting with clinical systems of record, such as hospital EHRs and primary care systems, different kinds of knowledge platform to allow reusable access to content and guidance and algorithms. And then finally, personal health record systems, because more and more we are starting to move towards that personally held data, PHR mediated model, where the citizen can use, create and reuse data across multiple services for multiple conditions, and that's increasingly important with an aging society, with more of us having more long-term conditions for longer. Next slide. So to that end, that kind of, the confluence of all that is we need infrastructure that can support products, services, apps, devices to be more meaningful in the context of an ecosystem. And chiefly, we are trying to avoid a plethora of point-to-point integrations, as lots and lots of different products, apps, services, devices connect with lots and lots of different public, third sector, private or independent care or service providers. And instead we're trying to figure out, and we're trying to provide infrastructure to say, what if the citizen held their own record? What if they could mediate between these systems? What if they could consent to share their blood pressure cuff data from something they bought off Amazon, or maybe some wearable data out of an Apple Watch or a Fitbit? What if they could share that with a pharmacy? What if they could share the dispensing data they have from a pharmacy alongside some of that wearable data with clinical record systems, for their GP or otherwise. What if they could take their health data out of health systems and bring it with them to social security or housing systems to demonstrate need or eligibility? I need to be rehoused because my COPD keeps exacerbating, and it's because my environment is too humid, and the house I'm in isn't fit for purpose, for example. How can a citizen accrue that evidence and without a lot of photocopies, letters, and weeks and weeks and weeks of agencies sending materials back and forth to each other? Can we give it all to the citizen? Can the citizen reuse it? And this is chiefly what people are asking for in our co-design with them. Next slide. So we then, sorry, you can't see this very well, this kind of size, but this is a kind of example digital service model. So we talked about design. So trying to understand how professionals would work and how citizens would live. So professionals along the top, citizens along the bottom, and how new digital co-management infrastructure can mediate conversations and ways of working between them. So you might have a clinician using TrackCare, SkyStore, DocMan, and other cornerstone clinical systems, and they will have their own workflows and their own EHRs and audit, and for various reasons they have to do things in a certain way. How can we integrate with those systems and add value to them rather than trying to replace them or create new silos? How do we make sure that the data that can move between these systems and a new generation of kind of responsive and structured data dashboards and other sorts of interfaces that help the professionals bring all the data they need together from their systems, but also from the patient? And how can the patient be equipped with new self-management and self-assessment and wearable and other other devices and point of care diagnostics and other kind of elements, and how, as George said, can we fuse those two worlds together using these sorts of integration technologies? Next slide. So I'll give you one example of this, just to kind of just give you a flavor of what we're talking about. So this is a piece of work called Dynamic Scope, which is being run by NHS Greater Glasgow and Clyde, and has just started to scale out into NHS Lothian. And this is a model that is mediated by a health data exchange. That health data exchange is a citizen consented bridge between that personal data domain and the clinical data domain. And so the citizen can connect the health data exchange to their Fitbit, to their home respirator, to an app that they have on their phone that allows them to collect PROMs and PREMS data, so experiences and outcomes like their fatigue or shortness of breath, and all the data from their physical activity, their sleep, their ventilator data, their experiences. All that data is then they can consent to share that through the health data exchange into clinical systems, and the clinician can then see that on a specially built dashboard that connects onto the other side of that health data exchange, which in turn integrates with those core clinical systems like TrackCare and DocMan. What that means is the clinician can see everything they need to see from their investigations and core clinical records, alongside everything the citizen is providing, which includes their physical metrics, their well-being, and other bits and pieces that are being brought in via that data exchange. Then obviously machine learning algorithms can work across the top of that kind of data and help clinicians to kind of risk stratify those populations that they're caring for, and understand who might need intervention, and try and get ahead of the game, predicting exacerbation, morbidity, or risk of readmission. And through these kind of models, so far Glasgow has reported through its initial trials big reductions in admissions, but importantly reductions in community respiratory reviews. And so I guess the point here is you don't need to have appointments to manage clinical risk if you're always managing clinical risk. And at that point, then any face-to-face care interactions is more about care and less about clinical risk management. So new models can emerge at that point with more community groups and more care near the home, might be provided by charities and other groups as well as the NHS. And there's new ways of working because that clinical risk can be managed in this way. Next slide. So just to finish up, I guess the offer here is when we talk about these person-centered infrastructures, we are interested in them both because they put the citizen in the driving seat and empower them, but also importantly because they open up the ecosystem from an innovation point of view. So both the health data exchange that we have procured, developed and provided, but also personal data stores and new types of clinical data repository, and also personal health record systems. We procure and deploy all of these systems as an innovation center, and will make them available to anyone who wants to work in this way. So we have sandboxes set up so developers can come in and access the APIs and access some dummy data and show us how their apps, devices, and other services can interoperate in these kind of models. And therein we can then demo those integrated systems into health and care teams to say, oh look, here's another group that's interested in working in this person-centered modular way, and all of a sudden you know there's more of a route to market in this model than you would otherwise have, banging on the side of the NHS house, but trying to persuade them to let you integrate. So that's our basic offer is saying if you want to come and have a play, please come and do that. And we tend to only work with organizations that are wanting to work in that kind of integrated fashion. I think that's me.
That's us.
You want to stop sharing the screen? George, Michelle and Shal, that was absolutely fascinating. Thank you so much for taking us through this afternoon, the insight into DHI. I thought the statistics were quite scary, but with that comes opportunities, and obviously the benefit of changing mindsets, behaviours and outcomes, and also the benefit of collaborative and innovative working practices. Shal, thanks for the insight into how businesses can potentially get involved with DHI. I'm not sure that we actually have any questions that have been posted by our webinar participants. I have one, if nobody else has, around have there been any innovations or developments that didn't work in the manner that you had anticipated, but were even better in their new iteration? In the same way that drugs often are used for different things than they were originally intended for. I just wonder if you've come across that in DHI.
I guess the one that springs to mind was some early work we did in our first couple of years with a company called AliveCore around two lead ECGs, from a pad affixed to your smartphone. It was a kind of very, I guess, an early first to the breach kind of point of care diagnostics offering, and we had to do some gymnastics to get the NHS to experiment with this. The idea that a citizen could perform their own diagnostic on themselves on their own phone scared the bejesus out of the system, because you can imagine the kind of the threat of the worried well coming in their droves into A&E, going, oh my god, I've got an irregular heart rhythm, and panicking. And so we had to come to an accommodation where for the trial, GPs would effectively have it in a GP practice, and so when people popped in for their regular checkup, they could just put two fingers on these pads, and 30 seconds later they'd have a rhythm detected, and that was a kind of compromise because it was kind of managed by a professional, and that wasn't as scary. And 2 years later, it's now common in Apple Watches and other wearable devices. So all of a sudden you're like, oh, that horse is completely bolted. What we thought was a kind of mediated, gently kind of approach, because we had to do it that way, because otherwise the clinical community it was quite concerning to them. The consumer market has just vastly outstripped what we would deem to be acceptable if that makes sense. And so, and now anyone who buys an Apple Watch is able to monitor their own atrial fibrillation and rhythms. And I guess the world hasn't ended, would be my only kind of reflection on that. And that does tell us something about sometimes we are so concerned with the unintended consequences that we don't even start.
Yeah, well, I guess a lot of people who are training use their heart rate monitors to regulate how hard or slowly they go with their training for events. Anyway, I'm conscious of time. I think you have given us an immensely interesting insight into DHI. So again, thank you very much for coming along and sharing your presentation this afternoon. It's hugely appreciated. For those of you on the webinar, if I can just thank you for attending. If I can ask you not to forget to follow us on our social media channels, that is Facebook, Instagram, LinkedIn and Twitter for updates on everything that's going on within the district. And please feel free to reach out and keep us up to speed with anything that you want to share with us. The website for Glasgow City Innovation District is www.glasgowcityinnovationdistrict.com. And thank you very much for your attendance and interest in the event today. So without any further ado, I think we'll bring the event to a close, almost on time. I'm only 3 minutes over. So thanks again to George, Michelle and Shal. And we'll look forward to seeing you at our next event in due course. Thanks, everybody.